Artificial Intelligence, Personalized Technology, and Mental Health, in partnership with the Artificial Intelligence Program at the University of Michigan.
Good evening, and welcome to Friday Night AI. My name is Rada Mihalcea. I'm a professor in the Computer Science and Engineering Department at the University of Michigan, where I also lead the Artificial Intelligence Lab. And we started the Friday Night AIs earlier this year with the intent of fostering a conversation between researchers and the local community. So we are very excited to have you here tonight to discuss a topic that I think is very both interesting and important, which is the interactions between AI and mental health, both assessment and treatment. I would want to say a little bit about the format for tonight. So first, we'll start with some introductions. So we'll want to hear more from our speakers, and there will be a few questions that we'll start with just to initiate a discussion around this topic of AI and mental health. And then we'll want to hear from you, questions that you have about this topic. So there are index cards that you received as you entered. If you haven't, you can raise your hand and somebody will help with that. And then we have in the back of the room, PhD student Ash Kazemi. He's a PhD student in the AI lab, and he will help this time with collecting the cards. So we'll get the cards here so we can try to cluster the questions that are asked from the room, and so that we have the speakers answer those questions. All right, so with that, I'm very happy to be joined today by Emily Mower, Provost, who is an associate professor in the Computer Science and Engineering Department at the University of Michigan. He is the director of the Computational Human Artificial Intelligence Lab and also a member of the Heinz Prechter Bipolar Research Program. And there she leads the development of computational methods of predicting mood swings of bipolar disorder. And we have Emily's long-term collaborator, or the other way around, Melvin's long-term collaborator, Professor, both ways, Melvin Mckennis, who is the Thomas and Nancy Upjohn Woodward Professor of Bipolar Disorder and Depression, also the director of the Heinz Prechter Bipolar Research Program, where he leads a team of over 30 faculty and staff who work on various projects on bipolar disorder. He is also the Associate Director for Research at the University of Michigan Depression Center. And with that, I will start with the first question. For the audience to get to know you better, I'll start with Emily. What brought you into AI and what keeps you in AI?
Yeah, so AI is a really exciting area, and part of the reason why I like it so much is that it gives you an opportunity not only to try to create really new and really innovative algorithms, but when you put a human-centered swing into AI, then you also have the opportunity to really join engineering and science. And what motivates me is that anytime you have algorithms that work really well, not only do you get the satisfaction from having something perform more accurately than it used to, but a lot of times if you're conducting your experiments appropriately, you actually get to learn more about human behavior. And fundamentally, one of the things that I was always interested in growing up was learning more about human behavior. And in fact, that was one of the early things I thought I would study. But I decided to pursue a trajectory in engineering. And I really thought I was going to do something totally different. I think that a lot of times when we talk about our life trajectory, we talk about it in a really linear way. Well, when I went to grad school, when I was getting ready to go to grad school, what I thought I was going to do was create the next generation of robotic hands, because I had recently rewatched the Star Wars release. I was extremely motivated by creating Luke Skywalker's hand, and every single graduate application essay I wrote, including for awards, were all about making hands. And then I got to grad school, and neither of my advisors did that, which I knew in advance. I swear I knew that in advance. But they did really interesting work that was at the overlap of human-robot interaction and effective computing, using speech to understand behavior. And to me, it seemed like a really interesting opportunity to do something meaningful, to do engineering that had impact on people's lives. And so over time, I specialized and started working in emotion recognition. where the goal was to take in speech and try to quantify ambiguity that's associated with how people express emotions, which was exciting and used to be something that I'd have to say, well, this is part of engineering because we need to have technology that understands us. But effective computing is in so many places now that it's not even as important to really justify why it matters so much. And so then I got to Michigan, and through chance encounters, like so many amazing opportunities start, I got to meet folks at the Depression Center who said, hey, we're really interested in trying to understand how mood, where in this case mood would be in terms of mania or elevated energy and depression or lowered energy, are reflected in the voice. And I thought, fabulous, that sounds just like emotion recognition. I will start on this problem and I will solve it in 1 minute. As it turns out, this is extremely hard. And we've been working together for 7 years now, really trying to figure out how you can take ambiguity at so many levels in terms of interpersonal differences, in terms of when people are deciding to share how they're feeling versus masking how they're feeling, depending on how strong someone's symptoms are versus how healthy they're feeling. How can we take all of these sources of ambiguity, extract things that are meaningful, and then contribute in some way to someone's long-term health? And so I've felt really honored to be working on this research project for as long as we have.
And
Thank you.
Melvin, what was your
Thank you very
career
much.
path?
Yeah. So my name is Melvin Mckenna, and I am a professor of psychiatry here at the University of Michigan. I've been interested in bipolar disorder for over 30 years, and I remember the day when I decided bipolar disorder is what I want to study. As a young physician, seeing someone who comes in an electrified ball of energy and in the manic state, and then within a couple of weeks getting them back to the regular person that they are, only to see them come in a stupor, a state of depression a year later, and then giving them ECT, treating them effectively, and they're on the phone complaining about the food in the hospital. And you have to ask yourself the question, how can the human brain generate such a diversity of energy states, of dynamic states in the individual? So bipolar disorder is characterized by recurrent manias and depression, and as Emily alluded to, energy is a profound element of it. So there is just this wide range of energy states in the individual. And my interest in artificial intelligence began really with an encounter with a patient and their family member in the emergency room many years ago. And I was talking to the family member, getting a history of how this state had developed. And the family member said, Dr. Mcinnis, there was something, I don't know, I just could hear it in their voice 10 days ago. There was something different about it. There was something that was changing. I couldn't put my finger on it, but there was something different. There was something there. And so it was, again, a series of encounters where Emily and I met, and we said, I think that there must be someone, you're interested in speech and emotion. There's got to be something there, because it's there clinically. You talk to any family member or anyone with bipolar disorder, anyone with a mood disorder, and they will tell you, yep, you can hear it in their speech. People that are in college, they will say, my parents, they talk, they say, what's wrong, John? And so they can hear it within a few moments. So our work is to identify biological markers that are, or physiological markers that are in speech. So how can we teach the computer, how can Emily teach the computer to do what the family member is doing? I can hear it, there's something in their speech. How can we develop objective measures that will be useful in identifying high-risk periods for individuals with mood disorders such as bipolar disorder? And we study bipolar disorder because I think there's going to be a lot that can be learned from bipolar disorder for depression and for other health states.
So thinking specifically about mental health, which are some of the ways in which AI technologies can assist with diagnosis of mental health?
So we've had a lot of conversations with clinicians, especially more recently, really trying to understand where does AI slot in. Because again, coming from a technology standpoint, you often assume, I understand how this works. I'm going to build a system that is in line with my understanding of the health system, and then I will change the world. But as it turns out, the world exists in a certain way, and what you really have to do is figure out what's needed. And so we had a lot of conversations with clinicians, and one of the things that we learned was that one of the major challenges that people are facing, particularly when people are originally diagnosed with bipolar disorder, is understanding medication. How can you identify medications that are effective, medications that allow people to stay healthy longer? And we learned that what people are doing now are things like tracking their sleep patterns. Because if you can have objective measurements that sleep is disrupted, then maybe the medication is partially to blame. Or objective measurements of movement. Because if you can understand how physical activity is relating to health, then perhaps you can have guidance for an individual that is reflective of how that person stays healthy. But one of the challenges that people have is that another thing that matters is someone's emotion. But if you ask me how I was feeling last week on a Tuesday, I mean, I have no idea. People are not very good at remembering things like this.
I would just say fine.
Yeah, and many people do, which is why it's so hard to use these measures. It's subject to recall, recency bias. And so we're really interested in thinking about how we can leverage technology to provide people with objective measures of how they're doing so that when they go in to show their clinician, they can say, look, this is how I'm doing. This is what my week has looked like. This is what my month has looked like. And it's these types of measures that will allow people to figure out what works well for them, to figure out medication adherence, et cetera.
I think that one of the most important, excellent points, Emily. I think one of the features that I'm interested in, and one of the challenges that I have in the clinic, is that the illnesses that we manage and help people manage are really a collaboration between the physician or the care providers, the healthcare providers, physicians, nurses, social workers, psychologists, a whole team of people, and the individual who bears the burden of the illness. Now, in the U.S., there are around 130 million individuals that have one chronic disease. Chronic disease just is an illness such as diabetes or something like or asthma or depression or something that is there, and we manage it. It was a humbling discovery as a medical student when I realized we don't cure very much in medicine. We don't. It's just not done. So we need tools. We need techniques to be able to get information over the course of the illness. And so remember, it's the time factor. It's how the illness develops over time, regardless of whether it's diabetes, bipolar disorder, depression, schizophrenia, heart disease, or whatever. All illnesses have a trajectory. And so where AI is going to be fundamental is in the ability to track the illness pattern of the individual. So we can learn and have objective measures and integrate those measures into computational algorithms to develop predictive models to say, are you, as Bo Schlembeckler, once said, you're either getting better or you're getting worse. And so that, so this is, being, that is binary in and of itself. But we need to know how things go over time or perform over time. Most illnesses, we benefit from not just a week's worth of history that's objective, we benefit from a month, 6 months, or a year. It takes me often as long as a year to get someone on track and stabilized with bipolar disorder. And so it's having, and these individuals can't remember how they were, now, or 6 months ago or last week, compared to how they are now. They just say, fine. And so that's where AI is going to be fundamental and going to be instrumental in our management of human disease.
But it's also where AI has a really interesting opportunity for collaboration because time series, from our perspective, time series are fascinating. They have interesting dynamic properties. They have changing baselines. They have periods in time where, in the case of health, interventions might be warranted. And these types of collaborations, I mean, not only do they have amazing implications from a societal, from a health standpoint, but algorithmically, they offer us the opportunity to say, what happens to models in the real world when we throw in real-world noise, real-world variability, interpersonal differences, recording differences? It offers an amazing opportunity for advancement on both sides.
And one of the things that we've emphasized in the Prechter program is the importance of side-by-side collaboration. In other words, researchers working together on real problems and applying the expertise in a integrated, collaborative way. So medicine is only going to be advanced when people come to the table together and work together, not just saying, okay, here's our data, please make sense of it for me, or here's some samples, please do what you want to do on them. So we need each other from the host of disciplines to solve this.
Yeah, and AI is only going to be able to contribute when we sit down with clinicians, sit down with the people who ultimately be using and benefiting from the systems to say, this is what I need. This is what's an important feature of my data. No, that thing you're measuring is just an arbitrary bug that you think is interesting but actually is not meaningful. But it's only through these continued collaborations on both sides that any real progress is made.
And I very much agree with that. I think that's something that we are seeing over and over in pretty much all the work that we do. And this is also a great lead into the next question, thinking about longer term, because you mentioned that both depression and bipolar disorder are illnesses that are long term. How do we think first in measuring mental health over a longer period of time, and also how AI can assist with that? So what would you do? Would you collect a lot of data? How do you make sense of that data?
So we had a meeting with the director of the National Institutes of Mental Health last week, and he emphasized the importance of getting objective data. Objective data are data that are measured, sort of like blood pressure is an objective measure. Asking someone how do you feel is more subjective, and even when you get a rating, rate your how are you feeling on a scale of 1 to 10, there's still a subjective rating to that. And even a physician such as me, who's had 30 years of experience in working with bipolar patients, even when I say I think this person is mild, moderate, or severely depressed or manic, it's still a rating and a judgment. So we need really clear objective numbers and measures. And so this is where Emily and her team really shine.
But what's also interesting is that we need the flexibility to recognize the fact that different periods in one's life might be associated with different types of stability. So if you imagine yourself in one of your most stressful times, but you were functioning and you were striving, I don't know if there are any PhD students in the audience, maybe it was a paper deadline, maybe it was something else. We all have these periods of time where it's a high level of stress, but we are thriving and we are doing an amazing job. And then you can imagine a time when maybe there wasn't a lot going on, but somehow it was really, really difficult to motivate. Now, one of the interesting things when you think about tracking behavior using any kind of objective measures is that those two periods in time have vastly different signatures. But if you think about this blindly from a machine learning standpoint, then that period of great agitation, you might think that's high stress and an intervention is clearly needed, but that's not when an intervention is needed. An intervention was needed when a period of low stress, when it might have been otherwise difficult to detect. And so the reason why longitudinal data, longitudinal modeling, but also really fine-grained monitoring and prediction is so important is it allows us to have systems that adapt with someone over time. It allows us to have systems that recognize that, oh, this is a period of lower stress, but given this, these types of actions are perhaps not healthy. Or this is a period of high stress, but given this, your behavior is still within a relatively functional and positive range. But it's because of longitudinal data, personalization, and the ability to understand variation over time that you can do things like this.
So before I move to my next question, I would like to remind people to write your questions on cards. Are there already cards that were written?
Hold your card up. Yeah.
If you can hold your card up, and Ash, if you can you help collecting them, and I could get the first round.
Yeah. Maybe while we're collecting, also I can just give maybe an anecdote of where we've come from, where we've gone on the project. So there's been a lot of hype recently about how a smartphone detection can be used to understand many aspects of health, and that's where we started 7 years ago also. And one of the things that's been really interesting is thinking about, okay, when you actually get out of the lab, how do you think about natural behavior? Now, from a speech perspective, we always assumed that all of the types of modeling that you can use in the lab would work really well, and what we learned is that there's just way too much variation in the world to get any signals at all that are meaningful. And so over time, we've started looking at, okay, given speech, what are the things you can measure from speech? Well, you can measure emotion. Well, what happens when you measure emotion? Well, you can look for periods in time that are associated with higher levels of positivity, or you look for periods in time that are associated with more energy, or you can look for periods in time that are deviations from baselines, or you can look for patterns in language that change. When you start to look at changes in behavior instead of changes in really low-level behaviors of signals, it's one of the ways where you can start to do things that are robust, that are generalizable, that are interpretable, that are meaningful. And looks like now we have some questions.
Yeah, if I could get those cards. I still have a couple of questions before we move on to the... Oh, there are more. Okay. So let me move on. And since we've talked primarily about health assessment, can we also talk a little bit about treatment? What are ways in which mental health can be treated, and also how AI technologies can help with that?
So again, in the management of individuals with any psychiatric disease and in many illnesses that are medical, we depend on the interaction between patient and the physician to say, are you getting better? Are things on the up and up? And the management of bipolar disorder, we depend on information from the individual. We depend on what we see and hear when we see the individual, and essentially a clinical assessment. So in management, we need markers, we need indicators, we need measures, we need the equivalent of blood pressure, we need the equivalent of the serum glucose, the blood sugar measures in diabetes. We need something that we can measure. As of this very moment, there are no reliable biological markers in psychiatric illness. There are none. There are reports of things, and people publish points that, gosh, we have this inflammatory marker, or we have this other marker, or another kind of measure that's more prevalent in individuals with bipolar disorder or other psychiatric illnesses, but they don't replicate. So it's vital, it's important that we identify measurable markers and measurable things that can help us determine, is the individual getting better? And so going back to what I learned from my patients and their families, they can hear it in their voice, and they say, yeah, he's sounding better. They will say, yeah, he seems better. I can hear it. He's picking up. There's a skip in his voice or her voice and that. So we need to be able to measure that.
And one of the topics that we announced for tonight is also personalized technologies. And we haven't really talked so far about personalization. So how do you see personalization? How can AI assist with that?
That's one of the great powers. Actually, one of our early studies took exactly what Melvin just said and said, how can we operationalize the fact that when someone is healthy, they sound like themselves, and when someone is not in a healthy state, they don't? And we thought, well, there's sort of a speech recognition, speech modeling technique called speaker verification or biometrics. And the whole idea there is you have a voice print that's collected when you are doing enrollment. That's when you're setting up your device. And then you compare against it. And then if it compares, your phone unlocks or whatever system unlocks that you're trying to unlock. And we thought, I wonder if we can use this technique, something called I-vectors or identity vectors, in kind of the same way to personalize our technology. And so we built models where we took enrollment data from when someone was healthy, compared against it to understand how deviations in how someone sounds with respect to themselves would allow us to understand that symptom severity was increasing. And we found it was effective. And really, the interesting thing about any of these approaches is that you can adapt models. A model isn't one thing that exists forever. It's something that can take in new data and change. It's something where you can have many devices learning about what one person sounds like or what groups of people sound like, and using this to understand how a model should evolve, how a model should be flexible to the fact that you're talking to your boss or you're ordering pizza or you're talking to a clinician. All of these things are different. All of these things are personal. And through adaptation at the data level, you can actually create things that are responsive.
And it's very important to be able to gather information and data with the individual over the course of time, because time and again I've had patients come in and say, yes, I'm fine, doc, I'm fine, everything's fine. And then only to realize there's a family member in the waiting room. And whenever there's a family member in the waiting room, they're not there just because that's how they want to spend their day. They're there because they've got something that they feel they need to tell the doctor, and the patient may be a little bit ambivalent about it. And that whenever I see a family member in the waiting room, I always have them come in and tell me their concerns. I don't keep them there for the whole appointment, but I want to hear their concerns. And so if we have methods like what Emily is developing, just to get a signature, a pattern over the course of time, that will show us, somebody whose mood is just going up and down like that, or up or down, or what the pattern is. That is fundamental in helping us design and develop and propose collaborative ways with the patient and their family to manage the illness at hand.
So the use of technologies in general, and for healthcare even more so, has important ethical implications. So how do we ensure that we are talking about data collection, that we respect the privacy of the people who this data belongs to? How do we build systems that would respect this privacy in the way they are being used?
We think about this all the time. So as background for the type of data we actually do work with, so we're really interested in how voice changes in periods of health. And one of the great things about voice is that it's very easy to collect. We're speaking quite often, and there's an easy way to collect it because all of us are holding extremely powerful computers with us all the time. And so what we do is we design apps, and the apps are designed to ride on people's phones in the background, and they collect calls that people make or receive, just their side, when they're using our study smartphone. Now, whenever we say this without any follow-up, that sounds invasive, right? We're collecting cell phone calls from people as they go about their daily life. But the reason why we do things like this, and I'll get to the ethics that we think about constantly, every day, every minute of every day, in a second. But the reason why we do this, the reason why it's important to work with data that are real, that are collected in this way, is because if you ever want a system that can naturally and reasonably understand someone's health, then you need to work with real data. And with real data, there always come ethical responsibilities. And so at a first pass, the way we think about this is that all of our studies are governed by our IRB. And our IRB ensures that we are consenting the individuals with whom we work. And it doesn't just mean giving them a long form full of many things that we read to them at a very rapid rate. No, we really make sure that the people that we work with understand exactly what we're doing and what we're not doing with our data. And we take it very seriously because our participants are our research collaborators. They enable us to do what we're doing, but they also provide us insight. They provide us with feedback. They provide us with grounding. They provide us with motivation for doing what we do. And it's also extremely important from an ethical standpoint to be very honest about what technology can and cannot do. Again, there are a lot of proposals, some of them more recently floated, to talk about how you can broadly use smartphones to do all sorts of things. And the important thing to remember is that behavior is important, behavior is meaningful, behavior tells us a lot, but behavior doesn't tell us everything. And it's extremely, extremely important to be open and honest about things that your systems can recognize, things like changes in symptom severity that are reflected in the voice. That's a thing that's reasonable to say. And things that they can't do, which is wide-scale tracking to track violence, which was a proposal that has appeared in the media recently. And so part of the ethical responsibility, just to restate, to recap, is being extremely open and upfront and careful with data that you collect, being extremely open and honest about what your systems can and cannot do, but then at the same time, being open to the impact of the technologies that could potentially result. And I know we had a lot of conversations at the beginning because I'm actually extremely risk averse. And I always thought, Melvin, nobody's going to want to do this. This is awfully invasive. But part of what I didn't understand is that also it is the participant's option to decide how to use data, and I think Melvin could cover this quite nicely.
Well, and so from an ethics standpoint, it would be unethical not to do this research. From my perspective, it would be the ethics of it and the driving factor of it is I work with patients with bipolar disorder. as I pointed out earlier, up to 20% of these individuals end their lives by suicide. So someone who goes into a manic state and it gets into a revved up state and is literally dancing on the table, selling everything, or doing, driven to do behaviors that are that have personal, social, and vocational consequences. I always say, listen, privacy, if I get into a manic state, my privacy is gone. Everybody knows what's happening to me. They can see what I'm doing. I have no privacy when I'm manic. If there is a chance that this will help me, I'm in. When I get depressed, I tried to kill myself one time. I'm here for reasons I do not understand. And so we are really, the importance of this work and the importance of what the findings there cannot be overemphasized. And it is fundamental to the study of humanity and the study of human disease. So it's an incredibly important direction that I think that this team is going.
I have the room has a follow-up question to that. So we are getting now to questions that came from the people here. So related to the question that I asked earlier about ethical implications, there is a question about how can we prevent discrimination or biases when it comes to also data and data samples. So how can we go about that?
Yeah, this is a real challenge. There's a lot of stories in the media now about algorithms performing poorly when they exist in the real world. And a lot of the reason why is that the data sets on which they're trained are biased, which means that the full diversity of people with whom the algorithms will have to work isn't seen before the algorithms are released. And so there are many ways to think about how to correct this. One, from an equity standpoint, is certainly collecting data that are reflective of the full group of people who will eventually work with it, another reason to get out of the lab and into the real world. There are also approaches that are looking at essentially how can you remove information from signals that people don't want to share. So let's say that someone does want to share their emotion state, doesn't want to share their gender for any number of reasons. Well, how can you introduce pre-processing to your signals that will allow you to control for information that someone does want to share and mitigate the impact of information that someone doesn't want to share? There are many ways to think about this, but all of them are important, because if you release technology that is designed for work for everyone and performs poorly for a segment of the population for whom you don't have data, or is leveraging information that someone didn't want to share, then this isn't technology that's helping anyone. It's technology that's exploiting.
So I also there's one fundamental element that I think is important to give consideration to, and that is trust. Mm-hmm. Trust is earned. We, the scientific community, have to earn the trust of the people that we serve. When someone, an individual comes into my office in a clinic, context, and I say, "Are you interested in participating in this research?" And he thought about it for 5 seconds. He said, "I trust you, and I'm going to do this." But I'm doing this. He made it very clear. He was doing it because he trusted us, the University of Michigan, to do the right thing and to be ethical and to really be sure that when we say something that we have the knowledge and the assurance that we've done our very best.
So another question, and you hinted at that, Emily, in your earlier answer. So there could be somebody coming to you that has no data. So you don't know enough about them to be able to, say, apply what you develop. And so the question then is how generalizable the methods that we have currently are to a new person for whom there is no data. There might be some clinical assessment, but you don't have the longitudinal data that would help with the application of AI tools. So how to handle those cases?
Yeah, so there are many possible answers for thinking about how to adapt models to a new individual. One of the ways you can start to do this is by creating models that are often, all communities use different words for this. We call them population general. That means that models that are explicitly designed and tested on people that the algorithms were never trained on. And so the question there is, given data that an algorithm has never seen, how well does it work? Because it's much, much easier to make an algorithm work on one person than it is to make it work on people it's never seen before. So the first step is often to have models that are population general. But then, particularly when you're talking about longitudinal data, you have this really interesting opportunity to collect more data over time. And if someone is providing you feedback for, how they're doing it, maybe a weekly level, in this week I've been feeling pretty good, and this week I've been feeling more depressed, et cetera, then you can start to build baselines that will tell you, oh, this is what this person looks like when they're depressed. This is what this person looks like when they're in an elevated or a manic state. And so you can start to have a model that adapts. And there are many different ways of thinking about doing this. It could be as simple as learning different parameters that said this is the range of someone's normal or more recent emotion state, and this is the expected variance that you'll see. And if someone's out of this range, then they might be in an unhealthy state. There are methods that you can look at that will relearn the model parameters over time as you get more and more data, so the model will eventually move closer to someone's own patterns. There are many different ways of doing this, but the important thing is having sufficient data about somebody so that you are confident that the model is moving in the right direction. So there's also, not to get too long-winded about this, but there are also questions about when can you trust a model that has incremental amounts of data to perform over a person's entire illness state. And so we've looked at this a bit and have shown that, at least for the participants we've worked with, about 2 to 3 months worth of data allows us to start to have systems that are performing better than our baseline systems.
And that's kind of how long it takes us in the clinic to get to know a patient and to get to know, how things are going over time. So in many ways, we're training the computer to think like a doctor.
And our computers
Sadly.
are...
Maybe that's not... I don't know whether that's good or bad.
I was going to say that as a positive. I was going to say our computers are highly, highly influenced by what our medical professionals tell us they should be listening to. Because again, one of the first things we did, we said, oh yeah, we'll just look at low-level speech features. These work well for emotion. They'll work well here. They don't. They don't, actually. It wasn't until we really got a good understanding for what human clinicians are listening for and looked at how we actually could pull that out of the speech signal that we started to find things that actually worked in the real world. So I'm going to say good thing.
And that's a good lead into the next question or set of questions about the current state of this project, your collaboration. Also, if you can speak even more to the kind of data that you would use for your system. So you mentioned speech, like low-level features. Is, for instance, even the phone location important, or how do you do about background noise? So if you can speak a little bit more about what kind of data you use for your project, and then also what is the state of the project and where you see this project, say, in the next 5 years.
Yeah, so we've been really, really lucky so far. So we've had this app that's been created by Arbor Moon, so thank you guys, that we've been using in the field for 7 years now, different iterations of it, but now for 7 years. And we've been able to collect 5,000 hours of speech, which is amazing for an academic institution. And within the last year or so, we've also been able to develop new, robust, and generalizable emotion recognition systems that have allowed us to work with these 5,000 hours of speech. Because privacy implications aside, it's very challenging to label 5,000 hours of speech, even if we were allowed to, which we are certainly not. And so we've been able to say, okay, given this person's past 6 months to a year, what have their emotion patterns look like? And we've been able to show that when people are in a manic or in a high energy state, they have statistically significantly or just higher levels of positivity and levels of energy compared to a depression state. And from that, we've also been able to say, okay, so we know that emotion is higher, but what can we actually do? And for a long time, what can we actually do is not something we focused on. We were just trying to focus on how bad are the symptoms. But to get back to something I said earlier, that's a really challenging thing to have your system output, because what's problematic for someone right now might be very different than what was problematic for someone last year. And so if you're just predicting severity, severity by itself is not actionable. It's not something that someone necessarily knows what to do with. And so over the summer, we worked with the folks at the Depression Center to do a new type of annotation, which was to say, given this person's history while they're enrolled in the project, and again, subject to subject to participant consent, when would interventions have happened? We can go week by week and week and say, should there have been an intervention now? Yes or no? What about now? Yes or no? What about now? Yes or no? And this allowed us to build a great data set of binary intervention yes or no predictions. And what we found is that you can use natural unstructured speech to make these predictions. And so we're moving more and more and more towards looking at how these types of unstructured data can allow us to automatically understand when an intervention, a human intervention, should actually take place. Another thing that we're doing, we're working with folks at Brown University, Butler Hospital at Brown University, to do something very similar for those at risk for suicide. And this is particularly meaningful because something that Heather, our colleague there, has told us so many times is that often before someone will commit suicide, the last thing that they'll say is, I'm not going to commit suicide. And so prediction is extremely challenging and extremely important. But what we're finding from emotion is that we can actually use variations in emotion to understand people at risk for suicidal ideation as compared to healthy controls. The other thing that we're looking at is how language patterns themselves change. When I've been talking about emotion this whole time, I'm talking as a very biased speech researcher to mean the acoustics of speech. Well, within the last years, I'm sure Radha will appreciate, language is actually particularly meaningful. And so we've also been looking at automatic measures of language, because again, we don't listen to the speech that we're collecting, but you can look at automatic transcriptions and treat them just as another measurement, and then look at how patterns in language are also associated with elevated risk. And so to make a long answer much shorter, I'd say that in the next 5 years, what we're interested in understanding is how to actually work with the intervention signals that our systems are predicting, how we can use emotion patterns both in the acoustics and in the language that people are expressing to really have a better sense for how someone's doing and when help is needed.
So another set of questions has to do with how well these technologies work now. How do we see them working in the future? At which point we are ready to, say, apply them in practice, whether by themselves or maybe as collaborators or assistants to a physician, and whether there will be sort of real applications in the near future for these technologies.
So one of the questions and one of the things that I've learned just in the past couple of weeks, is the concept of question zero. And so question zero is, what do you want to accomplish? What do you want to do? Why are we doing this? And so I want to just anchor ourselves back, back to question zero from a clinician's perspective. We need biological markers to help us predict, help us identify risk periods for needs of intervention, for suicide risks, for risks of untoward behaviors, including substance abuse or anything that would be not conductive to good health.
And from an algorithm standpoint, we need the robustness and generalizability to actually do this in the real world.
So, assuming we will be at the point where these technologies will be available for use.
Yeah, and there's every indication that I'm enthused by the energy of the engineers. I get energized just by saying, Melvin, this is working. It is working. It is going to work. We're really.
We have a lot of energy when that's happening.
Yeah, when that happens, and so that is so cool. So the next phase, then, Radha, what do we need to do? We need to do more research. We need to do more studies in order to prove unequivocally that this is going to work, because we need to have a degree of trust. We need to engender the trust in the population and the people with these illnesses and the people that we're treating, that we are on the right track and that this is working in the way that we want it to work. Is it identifying episodes or identifying risk periods of episodes? Can we lower the cost of healthcare with this?
Yeah, we need to really be able to figure out how does this impact things like quality of life. So if someone has longer periods of health, what does it enable them to do? What is it, both in their relationships, in terms of their financial well-being, in terms of their work life? How can these types of technologies support people to stay well longer?
So the question then is how And you alluded to that, Melvin. How do we make depression patients be willing to use AI technology? And I'm quoting directly from the question, given that most of them are not willing to see doctors in real life.
So that's a very important point. And so many of you will appreciate that when you go online looking for something for a health app. How many have used a Fitbit, for example? People, I've used a Fitbit. How many have used a Fit? Or you ask, I'm not going to ask this question, but many people use a Fitbit for 3 to 6 months, and then I went on holiday, and then I stopped using it. So this is a problematic thing with health-related apps, is that people will do it. It is a pain in the side, to have to fill in something. People are intrinsically lazy, including myself. I tried doing one of these things, and I did just to do it myself and filling out something. I did it for 3 months, and I said, gosh, I'm not going to. This is really annoying to have to do this. So we need to have technology like what Emily and our team are developing. That is, it's passive. It's just working in the background. It needs to be something that can be just active, the silent monitor. And for an individual with a long-term chronic disease, it's not just monitoring an individual for 6 months, 1 year, but it's 5 years. So what happens when somebody's going along and all of a sudden you realize things are starting to go downhill a little bit, and if your device can say, give an alert and say, maybe you should talk to your doctor soon.
And I think what's important also is that, again, when done correctly, when respecting of privacy, security, and ethics, then what it means is that your device isn't sharing anything with anybody except for you. And so what that means is that you can look at how you can track your own wellness, even if you're not sure you trust others. Or if you do, you can look at how you can share this information with others, with your care team, with your support network, so that you can be part of a team that's helping you stay healthy longer.
So there is also a question which alludes both to what you just said and also some of the ethical implications earlier. So without any AI technologies, there may be situations when a person thinks they are fine, but their friends or family feel like there is something not quite right with them. And similarly, there could be a situation in the future where a person thinks they are fine, but this AI system that's sort of assisting them all along is saying, well, you are not quite fine, you should see a doctor. So should there be things happening at that point, or should there be always at the latitude of the individual themselves?
So the important part here is that any technology is an instrument, a tool that is to assist the individual, and I always emphasize the importance of solving health-related problems with a health management team. And so it is, I do not want to see physicians, nurses, psychologists, and I do not expect that will happen, to see them displaced or removed out of the system and have AI there. AI is always and should always be an instrument that will augment the management of health.
AI is to help decision support.
Yeah.
So, and question which I think is interesting is going even farther into the future, maybe not that far, but would we hope for AI to show some self-learning or self-improving? So for the AI system themselves, as they observe, say, an individual or groups of individuals, would we hope for the AI to self-learn? So for the AI itself to get better by observing?
Yes, depending on the flavor of that question, yes. So I think that the goal of all of these systems is to understand what health looks like, where health is defined broadly, and understand how to detect deviations in health. Because if you can do that well in a domain like bipolar disorder, then you have tools to help in a domain like depression, or you have tools to help in a domain like post-traumatic stress disorder or anxiety or stress. And the question always is, how can you take systems that work well in one space and change them, adapt them with new data, adapt them with a new understanding for what patterns look like, and make them effective in another space as well? Obviously, there's also a negative way to take that question, but I will take it in the positive direction and say, yes, I think that AI can benefit quite a bit by learning from experiences and adapting networks, adapting models, adapting solutions that will allow it to be effectively used in healthcare.
And physicians and nurses and the whole healthcare team, they learn over time. So I am a better doctor to my patients the longer I know my patient.
And how about AI, the fact that we are using AI technologies and will use them more and more, would we hope for these AI systems to lead to new treatments, like maybe discovering new things about signals of depression or bipolar disorder and sort of paying back and providing some information to the physicians to learn new things about patients or new treatments?
So one of the things that we're very excited about in AI is the ability to take larger and larger amounts of clinical data, of research data, of data that derives from stem cell models, of data that derive from imaging studies of the brain, and data that derive from physiology, from biological tests in the individual. So the complexity of that data, if it's well done and controlled, is far beyond what the average statistician, what the average computational person can do. So AI is going to help us by these complex machine learning-based algorithms to take in multidimensional, multimodal data and generate new results to say, hey, you should be looking at this molecule or this gene or this mechanism for new direction. I don't know that it's going to discover, hey, this is what the best thing to do. It's going to help us, again, as a tool, to point us in new directions that maybe we didn't think about.
Absolutely. It kind of goes back to what I was saying was my original motivating factor. One of the great things about working in this area is that when you have engineering algorithms that work well, it means that you've taken human behavior, you've extracted out something that's meaningful, and you've understood how patterns and how it varies is related to something fundamental to who we are as people. And so I think it's very likely. One of the interesting things, I was just at a speech conference last week, and across so many different papers, actually, just as an aside, it's an exciting time to be in speech research right now because there are so many areas of these conferences that are actually devoted to how speech technology can be used in health. And so it's a very invigorating time to be part of this. But so many papers were finding the same thing again and again and again and across diseases, which had to do with how the variability of whatever signal they were talking about was one of the major things that was related to the ultimate health outcome. And so what's interesting about that is it suggests that engineering tools allow us to capture something that actually could be quite challenging to capture perceptually as humans. We're not very well attuned to what variability actually means. We can actually look at ways of quantifying these types of changes and looking for things that are common to tell us something more about how health changes. And just to briefly go back to the last question, because actually I do want to say one more thing about this idea of kind of AI and deployment and becoming more and more intelligent, et cetera. One of the reasons why it's also, other than the amazing benefits that these technologies offer, one of the really, I think, important reasons to stay with the development is that it offers the opportunity to be part of conversations, to be part of development, and to ensure that the ethical principles that you espouse are ethical principles that continue to be an integral part of how the technologies are designed and deployed. So ethics are a huge part of what we do.
And you are collaborating, so an engineer, computer scientist with the medical experts. Are there situations where you feel you are looking at something where you really need the other person? I would assume so. But would you... So when you say, Emily, develop systems with your students and you find yourself with data, how do you even know when you would need, for instance, Melvin expertise? If there is something maybe interesting or unusual that would need a medical expert to look at. So the fact that you do not have a medical training, and conversely, Melvin doesn't have like AI training, how do you deal with that in your collaboration?
A brief anecdote. So back in 2015 or 2016, again, we work with smartphone data, and we work with one side of a telephone call. And at the time, we were only focusing on clinical interviews. So that means that in a clinical interview, we have one side of the call, and that's the participant. And so what that sounds like, if we were to listen, from our end, would be large amount of silence, which would be the clinician talking, the patient speaking, large amount of silence, patient speaking. And so we were starting processing, and we realized something really, really weird, which was that when we changed out the algorithm that was segmenting speech from silence, our results got worse. And we thought, that's not intuitive. We would expect that when you remove silence and you're just processing speech, then you're going to isolate the signal that you care about, and that's going to be really effective. But that wasn't what we found. And so we took it to the extreme and said, well, what happens if we just keep all the speech in there? Or keep all the silence in there, excuse me. We had incredible results. And we went to Melvin's team, and we were like, Melvin, this is exciting. We found this amazing advance. And they were like, guys, this is a clinical interview. That means when someone is well, you have large amounts of silence, yes or no. Large amounts of silence, yes or no. When someone's not well, you have large amounts of silence, large amounts of speech. Large amounts of silence, large amounts of speech. Silence is a signal, but it's not a signal that has anything to do with the disorder. And so the reason why it's so important to work with people who are deeply enmeshed in the domain is they can tell you that these really exciting things that you're finding are not actual properties of the thing you think you're measuring. They're spurious correlations that have to do with the fact your data are collected in that way. And on the flip side, the other reason why it's so exciting to work with people who are experts in their domain is that it allows you to also curate incredible data sets that would never be possible otherwise. As I alluded to earlier, this summer we did this incredible annotation that allowed us to have a data set that not only has information about how speech varies with mood, but it also has annotations about when a group of trained experts in this area would choose to intervene given someone's clinical history. And that means that you have the chance to build algorithms that would never be possible if you didn't have this expertise. But it also means that the algorithms that you're building are doing things that are meaningful. And so the reason why it's incredible and critical to work with experts is it means you get to design things you wouldn't get to do otherwise. You get to avoid things that aren't actual findings, but are just spurious correlations in your data. And this is how you lead to real advances.
For me, I just want to say that I have learned so much working with the.
Same.
Yeah, you know, no, but I mean, it's I've learned more. I've had to learn more than you. Trust me. Yeah. And it is. It's such a refreshing thing. But the most refreshing thing is the questions that you get from the other experts and say, "What do you mean by this?" And so having to explain something that I assume that everybody knows, or that we have physicians think that the world revolves around them, and everybody thinks like a physician, and so on in the science, and it is humbling to appreciate the dimensions and differences in the academic approach to problems, and it's so refreshing to do that and to get the questions from the computer scientists.
Well, I think that's actually another important part of collaboration, which is that you're in a good collaborative relationship when you can say, as I did yesterday when we were meeting, Melvin, I don't know what those words mean. That's how you know that you're in a place where you're going to be able to continue to work together and actually do things that are real and meaningful.
So here is a test for creating a collaborative answer on the fly, maybe. A question from a student in the room who wanted to get some advice if they wanted to study AI and medicine together. How should they go about that?
Learn mathematics.
Learn mathematics.
Well, the things that I regret that I didn't do was to learn more mathematics in undergrad.
Yeah, I think, so I'm going to answer this actually as an engineer. So I think how I would actually define what I do is that my job is to listen to someone who's describing a problem and think about how I can design tools that will help them address that problem. And so I don't need to be an expert in the domains, and I'm not an expert in the domains in which I work, but what I like to think I am good at is listening. And that means that I can understand what the problems actually are, or at least after multiple conversations, get a sense for what the problems actually are. I can get a sense for what the things are that I actually can measure. I can get a sense for how tolerant people will be of those measurements, how people would like to use those measurements, and then I can help translate that into something that collaborators will tell me is meaningful. And so to the student, I think it depends entirely on what you want your role to be. If your role is going to be to figure out how to build the tools, how to design the algorithms that will allow you to address the problems, then it could be that the answer is being an engineer who's open-minded and is very good at listening. It could be that your goal is to understand the domain so well that you are going to design both halves of it, in which case, get an MD, PhD. It just depends on what you hope to do and what you hope to bring.
And you mentioned the word translation, so I will take it out of your context into the actual translation, what you often refer to. So a lot of the work, it seems that you've been carrying it out here, I'm assuming with patients who are from this culture, this language. Would you expect the kind of work that you do to be also applicable to maybe people who come from other cultures, other linguistic backgrounds?
Yeah, so we have a project actually that's winding down now, and so we asked a fundamental question: how can we ask specifically that question? And so we have in our area in Southeast Michigan an Arabic population, and so we have friends and collaborators in Lebanon. So I've been to Lebanon twice. We have a project that's winding down with Lebanon to see what the features, how people with bipolar disorder, how they're different and how they're the same in an Arabic-speaking population in Lebanon. Turns out they speak a lot of French too, and a Arabic-speaking population here in Southeast Michigan. And so we have now data set with several hundred hours of speech in it that we're now segmenting out to run the analysis on. So we want to answer that question, and we want to move into other cultures and test that. Test for differences. It's the differences. We appreciate there will be differences, but I'm interested as well. What are the common features in mania and depression, and what are the differences, and what differences are attributed to culture? What differences or what commonalities can be attributed to disease?
Yeah, when you think about the low-level acoustics, then clearly across different languages, the low-level acoustics of speech are going to be very different. That's, of course, how we realize that there are different languages. So at that level, there are fundamental differences. Of course, when you are also thinking about how to pull out patterns in language, the language itself are different. And so at the low level, both of these things will change. The other thing that's particularly interesting, and has been studied a lot in emotion recognition, is thinking about how different cultures express themselves emotionally. So the use of a smile, of course, is different across different cultures. People are differently willing to express their emotions versus others. There's a really interesting study looking at how people from the U.S. express their emotion, and it's much larger. Our expressions are much larger than in a lot of other cultures. And so really thinking about how your models are able to understand, again, what is the baseline for a given individual? Because it's not just the culture that influences how people's expression patterns different. It's also aspects of personality and temperament. And so this question about culture and translational differences have just so much to do with the same types of questions about personalization.
So with that, we could still take one or two questions from the room if there are burning questions or questions that have not been addressed. Is there anyone who wants to ask additional questions beyond those that we had on the cards? Do you have a microphone?
Do you have any evidence of a higher incidence of this disease among people who wear hearing aids? Hearing disabilities.
Hold your mic better. I didn't hear.
Disabilities, is there evidence of more cases of bipolar disorder in people with hearing aids?
So more cases with bipolar disorder in people that have hearing aids. I don't know that there is an appreciable difference to that. I think that there are differences in how it's expressed and how when people are hearing are using sign language. I've had interpreters help me with individuals using sign language, and the interpreter had a difficult time because the individual had kind of flight of ideas and sort of pressured expressions with the sign language and that. So there are differences in the manifestation and the expression of the illness. I don't think that there is a causal relationship between hearing and bipolar disorder. There will be an influence on the expression and the course of the illness because there are stressors that will emerge in the context of hearing compromised that will contribute to situations where depression or irritable states will emerge.
So we do have one more question on you as researchers, both of you. What would you say that most of your time is spent on while doing research?
That is a very interesting question. It depends on many things, actually. So time of year being a big one. So during this academic year, my days are split between many things. So I teach Intro to AI, and so it's in prepping classes and making sure that they're engaging, hopefully. Also in meeting with students and getting to hear about the interesting projects that people are working on, pitfalls, because for anybody considering a PhD, FYI, make sure that the projects that you're working on are personally motivating and deeply meaningful to you, because getting a PhD is a lot like a roller coaster where things are going very well and it feels incredible and you're finding these findings, you're making these discoveries, everything is working, and it's just fascinating. And then you get to the next paper and all of a sudden nothing works. And you get lower and lower and lower and more frustrated because you're throwing yourself against a wall and your algorithms aren't getting better, they're just performing randomly. And all of a sudden you realize the signal, and you chase that signal, and you follow your results, and you go back up until your next publication. It feels incredible, and then the cycle continues. And so a lot of it is trying to figure out where in the cycle my students are and what kind of feedback there is to provide. But one of my favorite parts of doing what I do is that as a single researcher, I can work on one, maybe two projects at once, but I can't do much more than that because there's not time, there's not the level of focus that's needed. But when you work with a team of really motivated students, you get to work in so many different areas because we also have projects. We used to do work in aphasia, although my students graduated. We work with people with Huntington's, people with Parkinson's. We also work with people at risk for suicide. We've worked with healthy students. And there are so many different projects you can tackle when you're working as part of a team. So there's also that. We also do service, which means what you do to support your own department's functioning. And so there's aspects of that. There's also supporting your community at large, so helping to organize events or workshops or doctoral consortiums, fundraising for all those things, fundraising for the research. There are many, many things that we do. One of the exciting parts, I was just on sabbatical last year, and it gave me the opportunity to really just focus on building tools, which I hadn't had a chance to do in about 7 years. And it was really exciting because I had a chance to code out an Android app. I hadn't ever coded an Android before, so I got to learn that. I got to learn how to structure various pipelines in speech recognition that I hadn't had a chance to implement before. And there, the problems were different. So my days when I was working on that were spent a lot of Googling, actually, because you go to build something and it doesn't work, and then you go to build it and it doesn't work, and then you build it and it doesn't work, and then you build it and it doesn't work, and it doesn't work, and it doesn't work, and then it works and you feel incredible, and then the next day you start again. And so it really depends on where you are in terms of your career trajectory, in terms of sabbatical. Summer actually looks a lot like sabbatical, which is pretty fun. But you just get to do so many different things on any given day, which is what makes the job so exciting.
So I spend around 80% of my time in research, 20% in clinical. And the problematic challenges that I have is at the leadership role is making sure that we have everything in place. We work with a lot of administrative things, regulatory, security, things like that. But the most fun of all is when we get to work with the postdocs, the students, and the people actually doing the research. And so they come and they said, "I've got this really great idea," and they show you it, and you look at the data, And then the ability to find something that you can say, well, did you, finding the right question. And so the point that is fundamental to research is back to questions. It's not so much the results are important, but what is the next question? So looking at the results, where is it taking you? What is the next question?
And a final question. What is the next
There are no final questions.
Just for tonight. So we've been talking primarily about mental health, specifically bipolar disorder, depression, and how you go about doing your research. So how generalizable and which parts of your work are generalizable to other mental conditions? For instance, anxiety, schizophrenia, and other conditions.
Thank you for that. That's a really good point. So the reason I love working with bipolar disorder, I love interacting with individuals that have bipolar disorder. I learn so much every day from these individuals because bipolar disorder spans the whole of human emotion. It spans the depth of depression is, in Dante's Inferno, and the height of mania is this electrified ball of energy that you amaze the human brain can generate, and all the dimensional elements there between. So it's my point, and I believe firmly that bipolar disorder, the study of bipolar disorder, and the breadth that it encompasses is going to teach us so much about human nature, about human behavior, about other illnesses. People with schizophrenia get depressed. People with bipolar disorder experience anxiety. People with anxiety experience depression. People with cancer experience depression. People with diabetes get demoralized and frustrated and have symptoms of depression. It's established clearly in the literature that individuals that have heart disease, there's an increased rate of depression amongst those individuals. So we firmly believe that our technologies are going to help broadly beyond simply bipolar disorder.
That was such a wonderful answer that I'll only answer very briefly on top of that, which is one of the great things about working with behaviors that relate to whatever it is that you care about is that if the behavior is a symptom that is generalizable, then you're creating a tool that's useful for so many people. And again, the one we work with is emotion. And emotion dysregulation isn't just for bipolar disorder. It's also for anxiety and PTSD and autism and depression and so many different areas. And so this same feature that we found to be so meaningful here, I think is likely to be meaningful in so many different places. And actually, one of the ways that we model language actually is a technique that was first used in schizophrenia. And so one of I think the interesting things about this domain is that it's humanity. There are so many things that link how we feel in so many different ways. And if we can just listen to people and create technology that captures those feelings, then we have the potential to really do something more universal.
All right. So I think we'll have to stop here. But the speakers will be around for just a little longer if there will be more questions afterwards. I will end by saying that the next event, Friday Night AI, will be on November the 22nd, still with AI as a central theme. November 22nd, we'll talk about teaching robots with natural interactions, and we'll have Professor John Laird and Joyce Chai being here. And so we'll hope to have many of you join us on that date. I will also mention for those of you who have an interest in the core technologies in AI, there is also a symposium coming up on October the 19th. Next week is the last week to register for that, so whoever is interested, please feel free. There is more information outside. And we are also looking for ideas for other Friday Night AI. So if you have a suggestion for a topic that you would like to see discussed, then we have papers out there on the table at the door, so you can leave a suggestion or just talk to one of us. And with that, thanks to all of you for wonderful questions, and thanks to Emily and Melvin for sharing with us their experience.
Thank you for moderating so well.
Thank you.
This program was recorded on September 27th, 2019 at the Ann Arbor District Library.